Well, thank you, the organizing committee of VIROC and Dr. Mohanty for calling me here. And it was a nice presentation by Vaibhav, and I also felt like presenting some of my plating and replacement cases, but here I'll stick to the nailing system. Now, so the background, as we all know, is that these periprosthetic supracondylar fractures are not very common, and they are usually difficult to treat because of the advanced age of the patient and frequently accompanying osteoporosis. Mind you, these are important words. As you can see, the entry point in an implanted knee is slightly posterior to the one which is documented for a one which is without one. Now, this is just an example how osteoporotic supracondylar fracture can be treated with a supracondylar nail. This is another example where sometimes the wire placements can help us to guide the guide wire, and it can help the reduction of the supracondylar fracture into a good reduction and a good successful outcome. Now, what are the important points for the nails is that it is not applicable to all designs of the total knee replacements. They generally require an open box femoral component. The smallest distal diameter of the nail is 11.5 for a T2 striker and the Trigen. The intercondylar distance must be more than 12 to accommodate the nail. If you ask me, it should be around 14 at least. The femoral component, if it is in flexion or in extension during implantation, it might interfere with the locking of the screws. The distance from the anterior femur osteotomy phase to the anterior edge of the open box is also important, otherwise it might lead to fracture of the anterior cortex or perforation. Now, this is a very good article by Thompson where he has tried to analyze all the different types of femoral components which with their intercondylar diameter and the distance from the anterior osteotomy phase, so that he has analyzed which are the ones which are compatible with the nails and which are not. Now, this is a whole list of existing implants till 2013 that he has done. It's a good article and it is very, very informative. I have tried to summarize the ones which we use commonly. Here the Biomet is all okay except the stem component. The DPU is all okay except the high flex PS with the closed box. The Zimmer Next Gen CR is no, the Zimmer Next Gen PS is yes, and the Exactech is also no. Now, some of the results said that the Biomet AGC cruciate retaining and the posterior were the only components which were compatible with all the nails. The other TKR process is not compatible because the force required to gain entry, scratching of the femoral nail and the posterior entry point to gain entry into the notch. Majority of the standard size retrograde nails are technically feasible, but they are not compatible due to excessive force required for insertion, damage to the nail during insertion, and the risk to the anterior cortex. As you can see here, the tip of the proximal end of the nail is almost abutting in the anterior cortex and sometimes can perforate and give rise to a fracture. Some of the important points that were brought out during the cadaveric study is that a very significant knee flexion is required for introduction of the nail, and the posterior stabilized implant require more flexion. The constant posterior axis deviation while introduction of the nail may lead to extension deformity of the fracture. As you can see here very clearly, the fracture is united but it is in extension because of the posterior entry insertion of the nail. Here also, as you can see, that there is an extension deformity because of the posterior entry and the less curvature of the nail. So what are the advantages is that if you have to exchange the liner, then you can do through the same anterior approach from where you are introducing the nail. The same midline incision can be used. The intramedullary fixation always better than extramedullary. The current nail with angulated locks, it helps to all kind of fracture geometry. Disadvantage is that it cannot be used for a closed box. Even with an open box, you need at least 14 millimeter. So undersized nail will be used, which may lead to less rigid fixation and the screws interlocking may be blocked, and there could be an extension malunion. Sometimes a burr may be needed to enlarge the opening for the entry of the femoral nail, thus introducing metal debris into the arthroplasty. So these are some of the papers which have compared the nailing with the plating system. It says that there are higher non-union rates with the plating method and higher refracture rates with the nailing method. This is at the tip of the nail. Some of the other papers also suggest that the non-union revision rates were similar in plating and in nailing. And it says that the orthopedic surgeon must train themselves with both these techniques, retrograde nailing and the locking plates, because they could be required to do, a combination, or it could be anything. So it is very important to know these. More articles on these. It says that a meta-analysis says that there is no significant difference in any of the outcome measures, whether you do a nail or plate. Another article it says that, this one article says that as regards to fracture healing and the treatment related complications, the intramedullary nail fixation has slight advantages. Now, this is another one which is obviously a little bit too advanced, which is an arthroscope assisted nailing. I'm just going to now brush through a few new nails which can help you through this. So this is a new nailing system which is improved fixation by reduced toggle and loss of reduction of the distal femur. As you can see here, the AO has got a mediolaterally flattened nail, so the diameter becomes 11.2, so it can fit through a very narrow box. This is another modification of supracondylar nail, wherein the normal nail is 5-degree curved, but the 10-degree bend in the nail will avoid the extension deformity. So these are important things, developments. The condylar nuts and washers will improve the stability as compared to the standard screws. And locking attachment washers will increase the fixation strength by 44% as compared to nailing alone. Now these are some of the jigs where you can introduce polar screws in either in mediolateral or in anterior-posterior direction, wherein the nail will be center and the reduction of the fracture will be accurate. These are some of the jigs where almost at almost 70-degree you can fix the fracture. So almost any geometry of the fracture can be fixed through these systems. This is a Phoenix retrograde nail where there is locking mechanism and there is a core lock technology. So it allows the distal screws to be mechanically locked to provide enhanced distal femoral fixation. So that's about it. Thank you everybody for listening to me patiently.